So, dermatology. Dermatology is the science that studies normal and abnormal skin and associated structures such as hair, nails, and oral and genital mucous membranes. Diseases located only at the skin level are very rare. More commonly, we have skin manifestations of systemic disorders. Skin diseases are very common, affecting up to one-third of the population at any time. Like allergy, they are one of the main healthcare expenditures in developed countries. When evaluating a patient, you have to take a careful history and directly ask your patients questions. They often don't volunteer information. For example, does the lesion appear and disappear? Does the lesion have any correlation with things occurring in the meantime? Is it in a particular spot? Patients seldom offer information if it is affecting the genitals or even if they have dry eyes. You must also concentrate on the appearance of the lesion because they can change over time. You must ask for any other illnesses, medications the patient is taking, the allergic history, and the family history of skin disease. Then you must be able to examine and describe the skin. We must inspect, making general observations, noting the size and number of lesions as well as their arrangement, spread out, clustered into groups, etc. Then we must describe the individual lesions using SCAM, which is size and shape. Size is the widest diameter, color, associated secondary change, and morphology and margin, the border. Then you need to palpate the individual lesions. You should check the surface consistency, mobility, tenderness, and temperature. Does the redness go away when you push it? Is it hard or soft? You often use the threshold of 0.5 centimeters, alpha centimeter, to discriminate between different lesions. You should do a systemic check examining the nails, scalp hair, and mucous membranes. Then you must be able to communicate what you have noticed when you perform the oral examination. You must indicate as well the distribution, configuration, and color. As for the distribution lesions can be generalized all over the body, widespread when they're extensive, localized when restricted to one area, flexural in body folds, extensor, knee, elbows, and shins, pressure areas like sacrum and buttocks, ankles, and heels, dermatome, where an area of skin supplied by a single spinal nerve, photosensitive with face, neck, or hand. For what regards configuration, lesions can be discrete, where individual lesions separated from each other, confluent with lesions merging together, linear in a line, target, so concentric rings, annular, circular or ring, and discoid or nummular with a coin-shaped round lesion. A typical annular lesion is tinea corporis, a fungus in the skin. See target lesions in erythema multiforme, annular in tinea corporis, and nummular in discoid eczema. Also remember that if the lesion that you're describing is pigmented, remember the ABCD of melanoma. So look at asymmetry. If there is asymmetry, irregular border, two or more colors within the lesion, and a diameter more than 7 millimeters. Then you look at the color. Redness is typical of erythema. The characteristic is that the redness, due to inflammation and vasodilation, blanches upon pressure. The dermatologist sometimes uses a glass to push on the lesion so that they can see how the color changes under pressure. Purpura instead is a red or purple color due to bleeding of the mucous membrane into the skin, which does not blanch on pressure. The purpura are palpable, which means you can feel the granules under your hands, and again they do not blanch over pressure. With pressure, it is an example of small vessel vasculitis. You should be able to recognize it. The palmar erythema, conversely, blanches when you push. Then you can recognize areas of hypopigmentation, such as pityriasis vesicolor on the left, which is a superficial fungus infection, or depigmentation, vitiligo, in which we have an autoantibody, an autoimmune attack against the melanocytes. So hypopigmentation and depigmentation. Then we can also have areas of hyperpigmentation such as melasma, which is an increase in melanin production in discrete area. It can be due to various causes, such as following an inflammatory reaction where there is a consequent restructuration of the tissue, and then the melanocytes produce more pigment than normal. This particularly occurs on the face. The primary skin lesions are concepts I absolutely want to take away from this lesson. You should be able to recognize the erythema, macula, patch, papule, wheal, vesicle, bulle, pustule, abscess, and nodule, like knots and gumma. This is the organization of the skin. You have the most superficial layer, which is the epidermis, and then the dermis. So, the epidermis is the outermost layer, forms a protective barrier preventing pathogens from entering, and helps regulate body temperature. It's composed of stratified squamous epithelium constituted mostly by keratinocytes. It contains no blood vessels. The dermis lies immediately below the epidermis and consists of connective tissue that cushions the body from stress and strain. It provides tensile strength and elasticity to the skin and harbors mechanoceptors, hair follicles, sweat glands, sebaceous glands, apocrine glands, lymphatic vessels, and blood vessels. Finally, there is hypodermis, which is not part of the skin. Its purpose is to attach the skin to underlying bone and muscle and supply it with blood vessels and nerves. Some lesions are mainly located in the epidermis, while others may be located at the dermis or epidermis-dermis junction, and so have different characteristics. The erythema should be easily recognized. This is what occurs, for instance, surrounding an insect bite. The erythema can have different shapes and sizes. It can be a point, landmark, lenticular, nummular ring, or circinata. You should be able to recognize the more common erythema, such as scarlactiniform, morbilliform, and roseola erythema. The rash caused by the scarlet fever, which is scarlactiniform erythema, is widespread, and erythematous patches are continuous without stretches of apparently normal skin. Then following the erythema is the squamation. The morbilliform erythema, mesos, is a little bit different because the erythematous areas are small and discrete. They are slightly raised and may coalesce to form plaques. These are not nodules or papules. If you push, they become white. Remember, erythema implies that when you press, the rash disappears. You can feel that the skin is inflamed, but there is no disruption of the vessels, so no red blood cells leaking out of the vasculature. In between the spots are areas of healthy-looking skin. Then we have rosacea erythema, in which the spots are more larger than morbilliform, rounded and paler, with a more regular shape and distribution. The morbilliform is much more irregular and much more inflamed. The rash usually subsides with flaking that can be like dandruff, pityriasis, or lamellar in scarlactiniform erythema. Rarely there is residual pigmentation, and the rash may precede or accompany other primary skin lesions such as vesicles or bulle. Then we have maculae, which are flat areas of altered color such as freckles, less than 1 cm, maculae, and they do not disappear under pressure. Patches are also flat areas of altered color but larger, more than 1 cm. You can also have changes in texture. For example, this is a vascular malformation giving rise to a vascular hemangioma patch. These kinds of lesions, maculae and patches, are located primarily in the epidermis. They should be discriminated from papules, which are due to a thickening of the epidermis epidermal papule, or superficial layers of the epidermis junction, dermal papule, with a size that exceeds the vesicle. So, the papule is described as being less than 1 cm and solid, while the vesicle is less than 0.5 cm and fluid-filled. You can really feel the raised skin under the fingertips. It is a solid raised lesion less than 0.5 centimeters. To the right is another example of papules. You see these papules on the ends following syphilis infection. Then we have the dermal wheal, which is due to dermal edema. The edema is soft and is the main lesion of urticaria, composed of many wheals. They can be small, like a grain of millet, or even giant. They generally disappear within minutes to hours, leaving no residual sign of the lesion. Then we have vesicles, which are lesions due to collection of fluid in the epidermis or dermal epidermal junction. They are raised, clear fluid-filled lesions, less than 0.5 centimeters in diameter. In acute eczema, Pomfolics dyshidrosis, they are quite easy to recognize. We don't know the pathogenesis of these lesions. They may become purulent influx of polynuclear neutrophils if they become superinfected. The distribution is important because there are viruses that give rise to vesicles. They can be located in clusters, for instance, and following the dermatome. These turbid-looking vesicles are due to a superinfection. The vesicles can be interstitial or parenchymatous. Interstitial vesicles signify edema of the epidermis, cell disruption and formation of a real cavity. Parenchymatous vesicles signify early destruction of some epithelial cells due to degenerative phenomena, and the consequential formation of a cavity in which liquid collects, for example in herpes simple, zoster, and varicella. The arrangement of vesicles is important for diagnosis. They can be grouped or scattered irregularly as in eczema, gathered in clusters as with herpes simplex, or down a vertebral body as with herpes zoster. With these diseases you get infected once and the virus lives latently in the nerve cell body or nerve root until you have a reactivation following a mild immune suppression, following sun or stress for instance. The trend is such that the top of the vesicle breaks prematurely, which is followed by a rapid revitalization, often accompanied by desquamation. In the case of deep vesicles, superficial erosions, often on the mucous membranes, may occur, after which follows reinstatement of the tissues. Other times the content is reabsorbed and the lesion dries with then flakes. Whenever we biopsy this, we have to take a sample from the periphery of the lesion because the center is often necrotic. Next we have bulle. They are big, they are clear, fluid-filled and more than 0.5 cm. There are certain autoimmune diseases of the skin that are characterized by the presence of bulle, such as pemphigoid. Bulle are circumscribed and tumefied suborneal, intraepidermal or dermoepithelial lesions constituted by a cavity containing liquid with a side that exceeds the vesicle. To the right is an example of bulle as a reaction to an insect bite. You can also get bulle due to friction from wearing the wrong shoes. Sometimes they can break, so you should also be able to recognize them as broken bulle. They may occur on apparently healthy skin, but more often are preceded by signs of erythema or erythema and edema. We don't know anything about the pathophysiology of pemphigus vulgaris. The usual evolution is constituted by the rupture of the roof, followed by an erosion and formation of a yellowish or brownish red crust. The repair is spontaneous with evolution towards an erythematous macula, followed by an achromic or hyperchromic patch. The bulle may also occur in the oral mucosa. One of the most difficult things to recognize are vesicles or bulle in the oral cavity because they immediately become ulcers. If lesions contain pus instead of clear liquid, then they are considered pustules. This is what we see in acne. Pustules are pus-containing lesions less than 0.5 cm in diameter. An abscess is a localized accumulation of pus in the dermis or subcutaneous tissues. Nodules are solid raised lesions of more than 0.5 cm in diameter with a deeper component under the epidermis. They are hard. This is an example of pyogenic granuloma, which is a granuloma telangiectaticum. Nodules have a dermal location around or oval, isolated or grouped into infiltrated plaques. They can be hard syphilis or soft in lupus vulgaris, cutaneous leishmaniasis. Granulomatous nodules from cutaneous leishmaniasis are ulcerated centrally. Some nodules are found in the derm-epidermal junction. They may constitute the elementary lesions of the erythema nodosum, which may appear as large hard nodules, often with a central depression or sarcoidosis. This can be an indirect sign of vasculitis. I've also seen nodules in the scope of rheumatoid arthritis, which is a bad prognostic factor as a sign of vasculitis and extra-articular rheumatoid arthritis. In sarcoidosis, the nodules can break and become superinfected. Finally, we have the gumma, which is another example of a nodule. It is a soft non-cancerous growth resulting from the tertiary stage of syphilis. It is a form of granuloma. Gummas have a firm necrotic center surrounded by inflamed tissue, which forms an amorphous proteinaceous mass. The center may become partly hyalinized.